Well, first of all, thank you for the opportunity to come and tell you a little bit about my RCT, which has a long name. The acronym is COPE. It's Cryoneurolysis versus radiofrequency ablation on pain experienced in chronic low back pain. A little bit of background. 577 million people will annually experience low back pain. In the literature, 4 to 25% of these will develop a chronic disorder. Majority of these cases are nonspecific, and 41% of them are due to facet joint, which is also the culprit and target for cryoneurolysis and radiofrequency denervation. So the objective of my 3-armed, single-blinded, randomized controlled trial is to compare the short-term and long-term effect of cryoneurolysis and radiofrequency denervation with placebo, both with or without physical therapy. So on this side, you'll see the setup for the study. We have screening, enrollment, randomization, post-procedural care, and follow-up. On this side, you'll see the inclusion and exclusion criteria of 2 I'd like to highlight: that patients had to have a minimum of pain intensity of NRS 4 or above, and also all had to have a positive diagnostic block. Below, you'll see all of the prompts we use for all the follow-up times, is particularly patient global impression of change at 4 weeks follow-up. So this is the intervention. We randomize 1 to 1 to 1, receiving cryoneurolysis, radiofrequency denervation, or placebo. And on this side, you'll see the needle placement. So all of our 120 participants received the same setup, received fluoroscopy, sensory stimulation to target the medial branch nerve. However, of one-third would receive a sound bite and no active treatment. And I made sure during the intervention to check if they actually could register getting an active treatment. And a few percentage actually felt they were getting some sort of treatment, even though I knew that the machine was off. For the results, we had 283 screened for eligibility. Of these, 141 participants were excluded, and 120 divided in 40 in each group went on to the intervention stage and the follow-up. For the follow-ups, we only had 6 people who were lost to follow-up after 12 months period. Here are the baselines for all of the 3 groups. It's a busy slide, but what is very important is that they were equally distributed, which we also know from the randomization. Marked in red are actually 2 factors, so gender distribution and alcohol intake that were different, and that I adjusted the primary outcome for. So here are the results. Firstly, we defined the primary outcome as PGIC had to be 1 or 2, meaning very much improved or much improved. Because when you do an active treatment, it is super important that the benefits outweighs the consequences. And in this, you'll see, which is highlighted in red, that our primary outcome here at 1 month, meaning before the physical therapy, we saw no statistical difference among the group. However, at 6 months, we can see that the cryoneurolysis group actually fared slightly better. But if you actually look at the p-value for all follow-up times, you might question if this is by chance or if it's truly an effect we can see. For other secondary outcomes, such as NRS, we again saw immediately post-procedural, probably due to local anesthetics. And for other secondary outcome, there were no statistical difference, either for function or for PCS. However, we can see at 3 months for the cryo group, they actually had a higher PCS score. Every study has limitations. For my study, it was the missing baseline, except for NRS. Secondly, one can always discuss the introduction of 1 or 2 diagnostic blocks, and of course the cutoff value, 50 or 80. In our case, we used 50. So in conclusion of this study is either neither cryoneurolysis or radiofrequency denervation showed an effect on patient global impression of change, pain intensity, function, and quality of life, rather for short time or long term. For intermediate phase, however, we can't really clearly exclude the fact that cryoneurolysis may have an effect. But we do also see that for PCS score, it is higher in that group. So thank you for your time.
Thank you, Kamilla. Great talk, great study. Actually, many questions. I think we also have one here. But can I ask you first? So maybe I missed it. So how many actually had a positive change? How many patients said that they had a benefit from the procedure, even if it was placebo?
So do you mean for when we did the intervention?
Yeah, no. So
how
if
many, they can feel the active.
How many said, because you're looking at the perception of change?
Exactly.
How many perceived a positive change? How many were in this 1 or 2?
We had around 3 out of the 40 with the follow-up who believed that they had a treatment who felt an improvement.
In the placebo group, and in general.
Do you mean for the block or for the
both cryoneurolysis or the denervation?
I would say for the cryo it was probably around 20, and for the RF also around the same percent, or maybe even lower. Okay. But it really does depend on which follow-up time.
Question from the Q&As from the floor. How did you decide on which level to intervene?
Yeah. So what we did is, what you can see from the flow chart, we actually had a pilot study. In that pilot study of 22 participants, we kind of had a consensus of how many levels we would treat. And as anyone knows, chronic low back pain, it's very diffuse, it's very heterogeneous. So we actually decided on bilateral and 3-level. Okay.
And a short final question, because we are running out of time. Mm-hmm. So what's your conclusion? Is your conclusion that it doesn't work to kill the ramus, or is your conclusion that not 40% of our patients have a facet joint problem?
So for me, in my conclusion, which I can only say based on, of course, the study I did, is that we found no significant difference in the patients we treated, but we also acknowledged the fact that there was an effect which we actually don't really know on which types of patients, which subgroup, in the 6 months of cryoneurolysis. So that's as much as I will say.